Okay, can everyone see that? Okay, perfect. So my presentation is on Introduction to Relative Energy Deficiency in Sports. I'm Alyssa Prashinsky, and I'm a student physical therapist from University of Nevada, Las Vegas. So before I get into it, I thought I would do a little bit about me. So I was born in San Francisco, California, and then kind of around elementary school age, I moved out to Henderson. There wasn't a very good picture of Henderson, so I just did the Las Vegas sign. But so I moved out there, and then I've been out there ever since. I earned my Bachelor of Science in Kinesiology at Pacific Lutheran University in Tacoma, Washington. It's a small liberal arts school up there. So but it was really fun. I did all 4 years up there. I also got a specialized business minor in administration while I was out there too. And then, so I graduated May 28th of 2022, and then I started UNLV June 6th of 2022. So it was a quick turnaround. But I've been having fun ever since, and I've enjoyed the program. So, and I feel like I've learned a lot. If at the end you guys have any questions or just want to keep in touch, my email is there, and it's my school email. So, but let's get into it. So the objectives that I want to hit today are defining relative energy deficiency in sports and where it came from, how to identify it with a patient, and then provide resources for clinicians and patients to treat relative energy deficiency. So to start, I just want to say that a lot of the information that I gathered is from the International Olympics Committee. So this definition actually came from their website. But what is relative energy deficiency in sports? It is a syndrome of impaired physiological and or psychological functioning experienced by female and male athletes caused by exposure to problematic low energy availability. And what is considered as problematic low energy availability is if it's been like prolonged or very severe. It is considered to be a clinical diagnosis, so it is something that has to go through their primary care provider and has to be screened out. So some outcomes of relative energy deficiency are decreases in energy metabolism, reproductive function, musculoskeletal health, immunity, cardiovascular function, and then a bunch of other things that were too much to list. But all of those things kind of compile and it'll lead to impaired well-being, increased risk of injury, and decreased sports performance. Decreased sports performance can vary between every athlete and vary between the genders, but in general, the impacts to athletic performance is a decrease in muscle strength, endurance, training response, coordination, and impaired judgment. So there is relative energy deficiency, and then there's also the female athlete triad. But back in 2014, the International Olympic Committee replaced the female athlete triad with relative energy deficiency in sports for the inclusion of all athletes, regardless of gender. So the female athlete triad was coined by the American College of Sports Medicine back in 1992. So it really took into consideration of mostly only female athletes, and it looked at the relationship between low energy availability, disturbances in menstruation, and low bone mineral density. So all those three things together really impacted the female athlete performance. So what low energy availability looked like at the time was with or without the presence of an eating disorder or disordered eating. So an eating disorder it's a psychological diagnosis. So some examples are anorexia nervosa, bulimia nervosa, and there's another one that I forgot the name of, but the concept of the third eating disorder is eating healthy or eating clean food. And then disordered eating is kind of like when you have 3 meals a day, one day, then you'll have two the next day, have one the day after, or if they're eating a bunch of like nutritious foods throughout the day, and then the next day they're eating a ton of processed foods. So sure, they're getting all of their meals in, or they're not during certain times of the day, or the nutritional value of their food differs day to day. So those can really impact the energy availability for performance. And then menstrual disturbances, so irregular periods. So that usually occurs when a woman or a female has their period for like a couple months, and then they'll skip it for a month, and then they'll have it again. Basically, it's just periods of time where their period does or does not come. And then amenorrhea kind of goes with irregular periods. Menorrhea is just a pause in menstruation or where a female doesn't bleed during that cycle. And then prolonged or heavy menstruation is when their period lasts longer than 4 to 7 days. And then heavy menstruation is when their period or their flow is super heavy throughout the whole time and it doesn't really decrease or let up at any point during their cycle. And then low bone mineral density is attributed to osteopenia or osteoporosis. Oops. There we go. Okay, so REDS in the female athlete triad, I wanted to do two visuals of it. So on the left, you have the female athlete triad, and it has all three things that I talked about. So that's what it was originally from 1992 to about 2014. This is the basis that we were working with as clinicians. And then once 2014 came, the REDS kind of encompasses the female athlete triad while also taking into consideration of other aspects of health. So it'll look at endocrine, metabolic, hematological, growth and development, psychological, so forth. But it has its little section there for bone health and menstruation. Okay, so then how do you identify REDS in a patient? So we're all really good at it, not knocking anybody here, but building rapport with your patient, getting them to build trust so that they can open up about their eating habits and open up about their health in general. So that's something that we really need to take into consideration of. And then just paying attention to detail. So if they're having inconsistent visits, so if they're coming a bunch of times and then they have a bunch of cancels or no-shows and then come again, just making sure that they're doing okay with that as well. And then their performance during therapy sessions. So if they're doing really good during some sessions, and then the next time they are like really struggling with the resistance you gave them, even though 2 days ago they did just fine, that can be an indicator of relative energy deficiency. But it could also really be hard to differentiate. So it's just things to take into consideration of. And then, sorry, my throat is dry. Whoopsies. And then subjective reports at the beginning of the session. So if they're telling you that they're not really eating so much, or if they're just super tired or just haven't been sleeping well, that's a really good indication. I have to cough. I'm so sorry. Okay. Anyway, so yeah, inconsistent visits, performance during therapy sessions, and then subjective reports at the beginning of the session. So there's a couple of athletes or a few athletes that are most at risk for relative energy deficiency. So athletes who play sports that are tied to success with a thin body, sports with frequent weigh-ins, endurance athletes, and then teams who have a big culture on like body shaming or heavy emphasis on winning. Some athletes that are tied to success with a thin body are like divers, gymnasts, and figure skaters. And then sports with frequent weigh-ins are like boxers, lightweight rowers, and then wrestlers. And endurance athletes are your cyclists, your runners, cross-country runners, and then your swimmers as well. For body shaming, if they're receiving a lot of pressure from their team, from their coaches or their teammates in general, saying that they need to lose weight or just making comments about their bodies in general. And then for teams who have a heavy emphasis on winning, that can lead athletes to not eat as much and ignore their hunger, or even possibly overtrain or overexercise past the limits that they should not be doing. And the general symptoms to screen for are fatigue, weight loss, missed periods or delayed puberty in female athletes, low libido in male athletes, frequent illnesses, hair loss, trouble focusing, inconsistent body warmth, and then irritability and depression. A lot of these symptoms kind of overlap with other diagnoses. So it's something to really keep into consideration of that. Is it possibly cancer within terms of like fatigue, weight loss, and hair loss? This is the most talking I've done consistently, so I apologize. But so some of these things kind of overlap with different diagnoses. So could it be cancer because they're experiencing like a lot of fatigue, or like unexpected weight loss if their goal isn't really to lose weight? if they have a lot of hair loss and then trouble focusing. So I know that cancer is a pretty extreme diagnosis, but they kind of overlap. And it's something that we should screen for and just make sure that we're focusing on what is at hand rather than just saying it's cancer or if it's not cancer. But yeah, just general symptoms to look out for, and that can kind of lead you down the path of it being relative energy deficiency. Oops. Okay. So if low energy availability is expected, you can use the International Olympic Committee Relative Energy Deficiency in Sports Clinical Assessment Tool version 2, which is a mouthful, but you can use that and it'll guide determination of level of sport participation for the athlete. It's pretty general. I have the PDF and I can email it to anybody who wants it, or just link it. But basically, it kind of walks you through how to do the assessment with the patient. And it has like, what's it called? It's like low, medium, high. So low, when you take them through the assessment, they're pretty much good to like continue with exercise. Medium is like they're kind of on the cusp of like, we really need to keep an eye on this and make sure that they're getting enough energy and getting enough fuel and sleep that they need. And then high is like this patient should not be participating in sports at all until they're able to really get the energy and the nutrition that they need. Within the assessment, there are some questionnaires to be utilized within the screening tool. So the top 3 that I saw within that assessment is the low energy availability in females questionnaire, the male questionnaire, and then red specific screening tool. There's a couple others on there, but those were the top 3 that I saw that were used within the assessment. So once you take them through the assessment and you take them through all the questionnaires, you can refer them out to their primary care provider or refer them out to whoever you think is best that would utilize this information to get them the care that they need. Okay. And then in terms of patient education, unfortunately, there isn't a whole ton out there for relative energy deficiency in terms of what we can give them, like so that they can manage it on their own at home. But what I found to be really helpful and at least like patient friendly is My Plate. It's a general nutrition resource to improve daily nutrition and caloric intake. It's very general, very much just easy to use and friendly. And it's something that we can like very much give advice on and how to use it. But this is just for them to really get or make sure that they're getting like their carbs, their proteins, and their healthy fats in every day to make sure that they have enough nutrition to participate in sports and even participate in therapy while they're here. And then the next resource is redinsport.org. It's a patient-centered educational resource on REDS. It's very user-friendly. Like if you were to look up the program, not the program, if you're to look up the website right now, it's pretty user-friendly. It takes you through the diagnosis, takes you through how like you do get diagnosed, what you can do and treat it at home, like manage it by yourself. And then it also takes you through like the outcomes of what happens if this were to be prolonged or pretty severe. For female or transgender athletes who do menstruate, I would recommend having them like conduct a menstrual calendar so that they do keep track of their menstruation so that it tracks like how heavy their flow was, what symptoms did they have during the day, and then how often are they getting their period. So if they're like skipping months or if they're like having it constantly, just keeping track of that so that they have something to report on to their primary care, or if they're seeing an OBGYN or their gynecologist, they have something to present to them to get it checked out. And then a sleep journal, which is pretty simple, just tracking their sleep for improvements in sleep hygiene and safe healing. Overall, in general, if our patients aren't getting enough sleep, then that can result in improper like muscle healing and then overall just not having enough energy to perform any exercises. So just very general stuff, mostly because there isn't a whole ton out there to really give to our patients. But these are some general resources that I found would be pretty helpful if a patient who has relative energy deficiency to give them starting out before they see like their primary care provider or whatever clinician they're going to see. So I know I did a pretty general introduction on the topic, but I thought it'd be cool to go through a couple patient cases and try to apply what I talked about. So the first patient case, your patient is a 15-year-old boy who participates in high school cross country and track and field. He is referred to physical therapy for post-tibial stress fracture with imaging showing that the fracture has healed. In his subjective report, he he said that he had severe pain during a cross-country event, with his athletic trainer recommending imaging, which identified a stress fracture. He reported it to his coach and has been out on injury until cleared to return to sport. You take all of your measurements and you ask him for his height and weight. Raintree flags you and says that his BMI is below normal. And then in objective measures, while you're taking him through the objective portion of his evaluation, bilaterally, his MMTs are -4 to 4, which could be pretty normal considering the fact that he hasn't been playing very often and he did have a stress fracture, so he wasn't being active at the time. His range of motion is within normal limits. His stability is pretty poor. He can't really hold a single leg stance for very long. And then you notice some atrophy, and he has some rounded shoulders and increased thoracic kyphosis. So he's pretty much in a slumped posture the whole time. So objective measures, pretty normal for his condition, with his stress fracture and the fact that he's a 15-year-old boy. He's not really going to care about his posture. But then in building rapport, he expresses that he has been receiving a lot of pressure from his coaches, parents, and teammates to cut in weight. And because of his injury, he's been less motivated to complete schoolwork, and he's noticed he's been a little bit more irritated throughout the day. So with all of these, you do screen further by asking about his nutritional intake. And he says that he skips lunch at school pretty often and he prefers snacking on processed foods. You ask him if he had any social support outside of his team and his parents, and he says not really. He really only hangs out with his team and doesn't have too many friends outside of that because he just spends so much time exercising and being with his teammates. You ask how his sleep is going, how many hours per night is he getting, and he says average hours of sleep per night is about 5 to 7, which isn't very good for a 15-year-old boy. We kind of want to aim for 8 to 10 if he can, but 5 to 7, not too great. And then you ask if he's had any recent illnesses. He says that he's been getting like frequent colds pretty much like once every 3 months. So from all of these findings, it should really kind of hopefully lead you down the path that maybe he's experiencing some relative energy deficiency, because some of these signs and symptoms aren't necessarily or they're not really consistent with having a stress fracture. There's a lot of social and like more immunity things going on top of his stress fracture. So you determine your findings to be consistent with signs and symptoms of REDS, and you refer him back to his primary care provider as well as a registered dietitian that is covered by his insurance. After he's done seeing his primary care and visiting a registered dietitian, he returns to physical therapy with an updated diagnosis of REDS and to be treated in addition to rehab for his tibial fracture. So when he comes back, you provide a little bit more patient education. You talk to him about his nutrition on top of whatever education he received from his registered dietitian, just to keep up with it and just to make sure that he is getting the nutrition that he needs. And then you provide some sleep education, so suggesting a sleep journal for him to keep. And then throughout therapy, this is my suggestion. You can treat however you see fit, but I thought it would be appropriate to do low intensity resistive and endurance training for him because he is a cross country runner, but also keeping in mind of his tibial fracture that he might not be as strong. And then if he also doesn't have the energy to do heavy exercise, that I think low intensity resistive would be the best way to go. And then you want to be in contact with his coaches and other clinicians just to keep up with them and make sure that they are aware of his condition and that they're not pushing him past his limits, or like making sure that he's staying away from that toxic team culture and just making sure that he is healthy and strong throughout his performance. And then other clinicians are just his primary care provider, registered dietitian, and maybe a psychologist if he decides to see one. And then the second case, your patient is a 43-year-old woman who participates in competitive weightlifting. She is referred to physical therapy for acute greater trochanteric pain syndrome. In her subjective report, she said that she noticed some moderate right hip pain that has been occurring for several weeks, which has impacted her training regimen. Her primary care provider referred her out to physical therapy. You ask her for her height and weight, and Raintree says that her BMI is normal. In objective measures, she is tender to palpation to her right hip and along the lateral side of that leg. Bilaterally, her MMTs are 4+ to 5, but they do elicit some symptoms. And then range of motion is within normal limits, but experiences a little bit discomfort in her hip. In building rapport, she states that she has started a new diet to compete in a lighter weight class. She has been experiencing some hot flashes often. Her periods are irregular and has had recent hair loss. So within building rapport, it should kind of lead you to decide whether if this is or if these are signs of relative energy deficiency or if this is signs of early menopause. She is 43 years old, so it is within range to think if she has been experiencing menopause or early menopause. There isn't any like one clear-cut sign of menopause, but her age and the irregular periods, as well as hot flashes and recent hair loss, could kind of lead you down that way. But because she's had recent or irregular periods, recent hair loss, and she is deciding to cut weight and start a new diet, that could also be leaning down towards relative energy deficiency. But you do some further screening. You ask about her menstrual cycle. She says that her menstrual cycle has skipped for 3 months. You ask about sleep disturbances or how her sleep has been going in general. She says that she's been waking up 2 to 3 times a night for about a month now. And then the new diet that she decided to start was the keto diet. You ask about psychological symptoms, and she says that she's been having some recent increases in feelings of anxiety. So because she's starting a keto diet, that diet kind of cuts down on carbs. So that is a big energy source for us. So that's kind of a red flag if she is a weightlifter and she's deciding to cut back on like a big nutritional portion of her diet. And then sleep disturbances, her sleep is pretty poor. So that can definitely add on top of energy deficiency. And then skip menstrual cycle, that could also be leading down towards menopause or relative energy deficiency. So if you're unsure about your findings, you refer out to a gynecologist and to her primary care provider about the findings that you have. After she's seen both of those clinicians, she comes back to physical therapy with the diagnosis of early menopause, but she was also on the path to early signs of relative energy deficiency. When she comes back, you just give her some patient education on the treatment for greater trochanteric pain syndrome that'll be effective with her early signs of menopause. And the nutritional resources, as weight loss and keto diet will severely impact her health. So you can send her to MyPlate, or you can refer her out to a registered dietitian or a nutritionist, whichever is going to be most convenient for her. Just making sure that she is kind of staying away from that diet so that she can keep up with her heavy weightlifting. And because she's going through early menopause, that's just not enough nutrition to get her through that transition of life. And then you want to communicate with her coach and other clinicians involved, so her primary care, her gynecologist or OBGYN, and then if she decides to see a psychologist or a registered dietitian. So I just want to tie it all back in. So scope of practice, it is well within our ability to screen patients for relative energy deficiency and provide general nutritional advice. It's just something that we can provide, and it's really not too much out of the time to like really give to them during initial evaluation or during treatment times, especially because this really does affect us as physical therapists. It'll affect our patient's ability to build muscle. It increases their risk for a musculoskeletal injury. And if we're not really understanding the signs, a lot of this stuff can get kind of swept under the rug, and it can also impact our motivation to participate in physical therapy. If for some reason you don't know what's going on or you're just in doubt, just refer them out. So you can refer them back to their primary care provider, a psychologist, registered dietitian, or nutritionist, or a medical nutrition therapy. One second. Um, most or the thing that I want to hit most on this topic is that it's an interdisciplinary diagnosis. There's not just one thing that we as physical therapists can do for them. It's they need all of their healthcare teams together to really treat this and really get them on the path that they need to be to perform as best as they can and to just be a healthy human being. Um, I also wanted to highlight that this is still an emerging syndrome that needs additional research. It really is only 10 years old, so there's not a lot of research out there to kind of help guide us, but that doesn't mean that we can't just ignore it. So even though there's additional research needed, there's still a bunch out there that we can utilize and help treat our patients now. It's just that there's not a lot of resources that we can provide to them besides the general ones. But if you do find that there are more specific resources that we can provide, then please let me know, and I would be happy to have them. And then treatment timeline, it really just depends, which is our favorite phrase. It really just depends on their sex, what sport they're playing, and how intense they are performing at, and how severe the relative energy deficiency is. If it's not too severe, then maybe they can progress a little bit quicker. But if they've been experiencing this for a couple of years now, it'll take a little bit longer to really get them back up to speed and back up to optimal performance. Oops. And then these are my references. And then if I have time, I have additional information to like go through and explain my thought process on some stuff. Yeah.
Yep, you go. Yep.
Okay, cool. Okay. So more on relative energy deficiency. So timeline of low energy availability leading to relative energy deficiency. So acute periods of low energy availability do not always lead to adverse outcomes. So acute periods are kind of like 1 to 2 weeks where they're just like not getting enough energy to really perform. But it's rather prolonged exposures of low energy availability that leads to relative energy deficiency. So timelines may differ between the sexes, and some signs and symptoms require exclusion for a differential diagnosis, which is why I kind of talked about like in the beginning when we're screening for things. I know I went pretty extreme saying like fatigue and weight loss could be a signs of cancer, but these are just some things that we really need to screen out before we decide like these are signs and symptoms of energy deficiency. So relative energy deficiency in male athletes, the magnitude of effects and thresholds at which they affect or which effects manifest at variable, between the sexes. So males can sustain a lower energy availability before psychological and or physiological and psychological disturbances manifest. So it may take a little bit longer to really determine if a male athlete is experiencing relative energy deficiency. It may take them a little bit longer to experience that because they have the ability to sustain that a little bit longer. I'm not saying that that's healthy to do, but it might be a little bit harder to really define it. And then energy deficiency in para-athletes. So the prevalence is undetermined. However, concerns that para-athletes may be at a greater risk for REDS than able-bodied athletes. This hasn't been studied too much. However, this is a big concern, especially for Olympic para-athletes if they are performing at greater levels or just about the same level as able-bodied athletes. And if they're not getting enough energy that they need, depending upon their impairment, this could really impact them and their performance when they decide to compete. And then mental health outcomes for relative energy deficiency. These are some psychological indicators that they might be going down the path of energy deficiency. So they can have mood disturbances or fluctuations, cognitive dietary restraints. So what cognitive dietary restraints are is where they think that they can't be eating or if they're not eating enough. Stuff like that. My next slide has eating disorders, so I'll go more into that on the next slide. But if they have a drive for thinness, reduced sleep quality, and then perfectionist tendencies. And then there's a difference between relative energy deficiency and then overtraining syndrome. So there is an overlap of symptoms, but the key difference between REDS and overtraining syndrome is low energy availability. And that should be excluded from an OTS diagnosis than a REDS diagnosis. And then these are some eating disorders to be aware of. So signs and symptoms of an eating disorder. So strict habits, dramatic weight loss, changes in personality, fatigue, dishonesty about food, skin and hair changes, low body temperature, changes in self-esteem, and then irregular periods. So these are signs and symptoms that kind of overlap with relative energy deficiency. Again, we just have to keep in mind like of what's going on. And if we don't know, just refer them out. But these are some signs if you believe that a patient does have an eating disorder. The eating disorders that I talked about earlier, so there's anorexia nervosa, which is restricting intake of food, which can affect individuals of all sizes and genders. So this is just when they're like, they just stop eating completely, or they just kind of eat like a bird. They just aren't eating enough when they eat breakfast, lunch, and dinner, or they're just not eating, period. And then bulimia nervosa is binging and purging. So they'll have periods of eating where they just eat a ton and they kind of stuff their stomachs, but then maybe an hour, hour and a half later, they bring it all back up. And then orthorexia nervosa, this is the one that I forgot the name of earlier, but it's obsession with health or only eating healthy foods and on top of overexercising, excuse me. This often leads to deficiencies due to cutting out whole food groups or underfueling for exercise. And then I wanted to highlight menopause because sometimes when we have patients who come in and they're around this age, sometimes menopause can be swept under the rug. So I just wanted to give it a shout out. So early menopause is before the age of 45, which kind of ties into the patient case that I did with the patient being 43 years old. Late menopause is after age 54. Then there's perimenopause, which is a menopause transition characterized by irregular menstrual cycles or 2 to 12 months of amenorrhea. Postmenopause is when a female has gone 12 months of amenorrhea, so they just didn't get their period for a whole year. And then some common symptoms. So cycle irregularity by greater than or equal to 7 days, skip menstrual cycles, or pronounced premenstrual syndrome symptoms. And then some signs and symptoms. Again, there's no one universal menopause symptom. That's supposed to say symptom. My apologies. But they can have a change in menstrual cycle pattern, vasomotor symptoms, so if getting those hot flashes or if they feel really cold all the time. And then vulval vaginal symptoms. So that can really just depend on the person. It could be differences in dryness for them or just like if they just don't feel very comfortable down there. It'll really just depend and if they want to talk about those symptoms. And then sleep disturbances, your psychological symptoms, so depression, anxiety, and moodiness. They can have changes in memory and concentration, joint pain, dry eyes, and then changes in weight distribution. And then that's all I have. So thank you. Thank you for coming and thank you for listening.